Okay, so hopefully by now you've all had a chance to, you're all aware that this document exists. It was in SCAI. I believe it was the first issue of SCAI, which is just such a phenomenal achievement for the society, and to have the first editor be Dr. Alexandra Lansky and be a female in interventional cardiology is really, I was really proud to see that, and happy about that. We worked with many people on this panel and around the world creating the SCAI expert consensus document on sex-specific considerations in myocardial revascularization, and I just want to highlight a few things about this document. So this document was a comprehensive review of the evidence for revascularization in our female patients, and you can see all of the topics we tackled. So it was extensive, and we had a lot of different groups doing extensive research on the available literature and how women and men compared, often trying to really cull out data that's not randomized in men and women, but from observational studies, from retrospective analysis of randomized trials, and small registries. So the whole point of the document was to summarize this evidence and to identify disparities in outcome that are not currently addressed in the guideline. So we can really allow physicians to understand when they're making recommendations what that's based on, and just be wary of making recommendations where there's very little data, and identify gaps that can help us prompt prospective investigation. This was a slide I was struck by, and you talked about it in your Hildner lecture, which is amazing. I mean, I entered residency in 1995. And at this time, look at the difference in mortality between men and women with cardiovascular disease. Everybody thought it took women longer to get disease and that they had a lower prevalence, and there just was not a lot of attention. And way back then, the guidelines from no data at all were more aggressive for prevention and treatment of coronary disease in men than women. So, different targets for lipid lowering and initiation of therapy, which really had no basis. And it wasn't until some pioneers in the field, and particularly women, started advocating and noticing that the trend started to improve. And you can see how well we're doing now since about 2012, 2013. And we've closed a lot of that gap in the mortality by really applying the treatments we have. We know that women and men have different etiologies of myocardial infarction, and a lot of what we're talking about today is atherosclerotic coronary disease, but we know that there's a lot more non-atherosclerotic causes and a lot more microvascular dysfunction in female patients. So we really don't know, because we haven't been systematically evaluating epicardial versus non-epicardial disease in these patients, what the true prevalence is with MI. I think we've learned more over the past decade as coronary angiography becomes a routine aspect of care of patients with MI, but in the past, when people were managed conservatively or had follow-up stress testing, we really had nothing to guide our information on. So right now, I think we're in a really good period where there's a lot of studies looking at the care of MINOCA, myocardial ischemia with an infarction with no obstructive coronary disease. There are several ongoing trials, randomized trials in the management of these conditions, both ENOCA in the stable setting and MINOCA, and we're looking to those studies to fill in some of these gaps. And then, of course, looking for ways to decrease mortality and poor outcomes in the non-traditional forms of disease. In terms of the diagnostics and invasive physiology in women, these were invasive parameters and cutoffs were derived comparing to non-invasive modalities. And what is repeatedly seen is that for a greater degree of angiographic stenosis, women are more likely to have a non-significant, non-hemodynamically significant FFR. And so it's concerning whether we're under-treating women using the same cutoffs as men. But however, when we look at the clinical data and the clinical outcomes and the benefit of using a physiology-guided approach compared to just standard angiography, both men and women benefit from the additional information and procedural guidance. When we think about why this may be the case, I like this slide a lot. And, you know, coronary physiology is inherently different in men and women. Women may have higher resting coronary blood flow and lower coronary flow reserves. And when you look at the discordant results between a non-hyperemic measurement like an IFR and a provoked one like FFR, you'll see that coronary flow reserve helps to distinguish why you may see that. And in patients with the low coronary flow reserve, they're more likely to have a negative FFR with a positive IFR. So it kind of leads me to prefer the non-hyperemic indices in women, and that's something we can certainly look at prospectively, is, you know, whether one tool is more favorable or whether we should actually be measuring coronary flow as part of the routine performance of physiology. That's all unknown right now. In terms of device consideration, one thing that's been really reassuring is that when women have atherosclerotic disease and they needed to be treated with coronary intervention and drug-eluting stents being our standard therapy for that condition, that the outcomes in women are very well studied based on collaborations from a WIN group and other groups. We have combined data from over 26,000 patients and including angiographic follow-up that show that drug-eluting stents perform very well in women equal to men in terms of the degree of late loss. I mean, certainly that doesn't overcome the smaller vessel size and potentially more negative remodeling and longer lesions, but the devices themselves, the drug-eluting stents, work very well in women. When we look at other types of procedures like atherectomy, we have much less data. We certainly know that there may be risk avoidance and avoiding using these types of atherectomy, rotational or orbital, because of the fear of dissection, because we know that women tend to have a higher rate of these complications. But the consequences of not doing appropriate plaque modification and having poor stent expansion or an unsuccessful procedure are, of course, even worse than the potential complications of these devices. So, and I know you'll hear today on the results of some of the newer devices like the Shockwave lithoplasty and IVL, which Dr. Lansky and the group presented the 30-day outcomes, and we'll have the longer-term outcomes were presented at this conference and will be reviewed today. So again, I think we know we can use drug-eluting stents, but we have to do good vessel prep, image-guided deployment and optimization, and then more to come on the plaque modification devices. In terms of revascularization options for females, I think the verdict's still out on when to do PCI versus CABG. And for the same syntax score, women tend to do better with CABG than PCI. So again, you have to do this as an additional variable when you're considering what to recommend. I just want to go through quickly in terms of acute MI. Young women are a particularly vulnerable population for doing poorly after acute MI, as we run into the various etiologies like SCAI and other things that people are not used to treating and don't approach in a uniform way. So we have to look at that. And then finally, the use of mechanical circulatory support in shock, because the data shows from these shock registries that if women end up on inotropes, and particularly more than one, that their mortality is extensively high. And the earlier that mechanical devices are placed, such as Impella, the better women do, and yet they're smaller and have higher bleeding risk. So again, there can be risk avoidance, and setting protocols in place to get women the care they need is really important. So just to summarize, there are still, it's good to recognize these gaps so that we can fill them, and also just don't be overconfident in interpreting data that was not studied well enough in women, and that way we can keep moving everything forward. So thank you so much for the opportunity.
So just by way of background, I think Don mentioned this, but after stent implantation, even long-term, this is out to 3 years, female patients with moderate to severe calcification have much worse outcomes in terms of mortality rates are increased, death and MI and revascularization rates are increased anywhere from 38 to 56%. So this is a very high-risk cohort of patients. As mentioned again, rotational atherectomy and some of the standard therapies for plaque modification in female patients are associated with worse outcomes, procedural outcomes. Not to say that they shouldn't be used, but we need to recognize that we have a lot more coronary dissections, tamponade, bleeding complications, etc. Our females are not really doing very well with current therapies. So this is the data we showed at TCT last year at 30 days. This is a pooled patient-level analysis, close to 600 patients, looking at the procedural outcomes of intravascular lithotripsy in our female patients. So procedural outcomes, you can see men versus women are similar, and that is new. We haven't seen this in this patient population. I have to say, I'm not going into the details here, but these are truly severely calcified lesions. And comparing that to some of the atherectomy trials, you can see that in terms of dissections, perforations, and other complications, we didn't see that in the IVL series compared to atherectomy. So let me now present to you the one-year outcomes. What we wanted to do coming out of TCT is really look at whether these results are sustained out to 1 year. And what this is again, patient-level pooled analysis of CAD3, 384 patients, and CAD4, 64 patients. That was done in Japan. You can see 5 countries and 55 sites representing 450 patients. Once again, 25% female patient representation. That's what it is. You know, in terms of the poolability of these studies, you know, all the trial design, endpoint, adjudication, follow-up, core laboratories, etc., were all very consistent. The endpoints were consistent. So I think, you know, it really justifies pooling these data together. Just wanted to point out here the peri-procedural MI definitions here, CK-MB greater than 3 times upper limit of normal. And again, this was done across the board in both studies. And the definitions of calcification, again, very, very consistent. So here we are, 448 patients, 106 females, 342 males. Excellent follow-up, so 98% follow-up rate at 1 year in both men and women. So just very briefly to go over some of the patient characteristics here. As expected, we have our women are slightly older, had less smoking, but otherwise, in terms of hypertension, diabetes, etc., we're very well balanced between men and women. The angiographic characteristics here, again, no surprise, you see smaller vessels. We always see that. And in terms of the lesion characteristics, again, very diffuse disease for both men and women, slightly shorter, I guess, in the female patients in terms of lesion length and calcified length. So this was, again, measured by the core laboratory, but 44 millimeters in women, 49 in men in terms of calcium length, and severe calcification in 100% of patients. So again, really high-risk cohort. The procedural characteristics, just to show some of the differences, procedural time was less in our female patients. There were fewer IVL catheters being used in female patients, and the number of pulses were slightly lower in women compared to men, but otherwise everything was pretty well matched in terms of post-dilation, number of stents, etc. And interestingly, more femoral access compared to radial access, not significant, but clearly trending. Looking at the outcomes in this series in terms of diameter stenosis, controlling for the differences in vessel size were very well matched. So pre-procedure, post-IVL, about 35% residual stenosis, and post-stent implantation, excellent results of about 10% residual stenosis. The differences in acute gain and MLD there are really driven by the fact that male patients have bigger vessel sizes. All right, so this is coming to the, again, the angiographic complications and dissection rates. Once again, we're seeing very low complications, severe dissections in a DNF in a very low number of patients, and less actually in our female patients than the male patients. Post-stent implantation, of course, no complications whatsoever. Here again, procedural success was similar between men and women. 30-day outcomes, completely similar. Again, no significant differences here. And here we are tracking out to 1 year. And you can see that major adverse cardiac events here was absolutely similar between men and women. Again, we have not seen this previously in all the other series. We tend to see the outcomes in female patients being much higher than male patients. And you can see all the components here of major adverse cardiac events. This is target lesion failure at 1 year. Again, consistent results, so excellent outcomes for our female patients. And the components of TLF, I think it's noteworthy, but numerically at least, lower rates of ischemia-driven target lesion vascularization and no stent thrombosis in our female patients here. So again, I think really outstanding results. So, what does this tell us? Essentially, from the CAD 3 and 4 pooled analysis, clearly the largest series that we have safe and effective results at 30 days, at 12 months. And again, I think the panel, there'll be a great panel discussion, but I think putting this in context of atherectomy and the results in those patient populations, I think that definitely represents a safer modality when it can be used. So thank you very much for your attention.
All right, thank you so very much for the opportunity to present this information today. And like Dr. Abbott and Dr. Lansky, who presented before me, I think we're all very excited about the level of interest and kind of really getting into these questions about if our female and male patients differ from each other. So this is a sex-specific OCT characterization of intravascular lithotripsy for treatment of calcified coronary lesions. Here are my disclosures. So this was a pooled analysis study design where patients that were enrolled in CAD 1 through 4 were included in this study, and specifically we were looking at a sub-study analysis of individuals that underwent OCT at the institutions that regularly were performing OCT measurements. The OCT core lab was sort of reviewed all of the OCT images for calcium morphology to evaluate visible calcium fracture and post-stent findings. And then also the angiography safety and effectiveness was evaluated. So this is just a sort of an overview of the patients that were included. Overall, we had 262 patients included in the OCT analysis. The core lab was at CRF in New York, and the target lesions were severely calcified adenoid lesions, and the reference vessel diameter was between 2.5 and 4 millimeters. So on average, similar to Dr. Lansky's cohort of patients, the women were older than the men, in this case by approximately 5 years, so significantly older, but otherwise their baseline characteristics were similar between the men in terms of hypertension, hyperlipidemia, diabetes, prior MI, bypass surgery, and renal insufficiency. In general, most of the women and men both underwent LAD PCI, followed by right coronary. And in general, women did have a smaller reference diameter compared to men, which isn't that surprising. Otherwise, the characteristics between the calcification were similar. It's, again, I just wanted to emphasize that we're talking about very complex calcified coronary lesions. These calcified lengths of, when you think about it, 40 millimeters of calcification length, with many of them being bifurcation lesions. These are very complex subsets. So as far as the procedural characteristics, there were no significant differences between men and women in terms of the overall procedure time or any issues related to delivery. Those were all 100%. The lithotripsy balloons were delivered. The number of catheters were similar between men and women. And you can see that the maximum pressure and balloon to artery ratio were similar. here are just some very nice examples of some OCT images. The one on the left representing the pre-procedural calcification. As you can see, it's really essentially concentric with very thick calcium. And then the post-intravascular lithotripsy image demonstrating some very, obvious fractures, which is it's great to see and confirms that you've modified the calcium, and then a really excellent lumen area after stenting. So I think that this is some of the most interesting, one of the more interesting parts of this particular study, and that's looking at, what are the actual characteristics of the calcium that women have. It's fascinating to me that, women do have, again, on average, a smaller minimum lumen area, again, that goes along with the smaller vessel size, but that their calcium angles and thickness were similar to men, and they were just as likely to have calcified nodules, and that the overall maximum continuous calcium angle was similar between men and women. And in general, they had a similar response to lithotripsy with a similar number of visible calcium fractures, as well as the fracture depth and width. Post-stenting, the OCT measurements were really favorable between, for both men and women, in that they all had sort of an increase in their luminal area. But again, because women started off with a smaller vessel size, they still had a smaller lumen area following PCI. Again, that sort of goes along with what we know about women and their anatomy. And the mean stented area was smaller for the same reasons. But the stent expansion overall was similar between groups, essentially representing that women had a very excellent response to lithotripsy, similar to the men. As far as the final angiographic outcomes, we found that women, similar to men, had an excellent post-stent diameter stenosis, which is greatly improved from baseline, and that they had essentially across the board no complications both in men and in women, which is really reassuring, especially framed in reference to what we know from prior atherectomy trials. So in conclusion, this present individual patient pooled data analysis is the largest analysis of sex-based OCT findings following lithotripsy treatment, and overall calcium morphology and visible calcium fracture characteristics were similar between men and women, essentially indicating that we should be treating men and women similarly, and that we had excellent stent deployment and safety outcomes in both groups with no difference in stent expansion, and that this really supports that the clinical safety and effectiveness of IVL for both men and women. Thank you.
All right, we're going to go to the first case presentation with Kathleen Kearney from the University of Washington.
Thanks. So this is a patient, I'll say, this is probably the worst case I've had recently where I used Shockwave. It's not really an issue with IVL, but I think treating calcific disease is always an adventure, and sometimes even when we think it's going to be straightforward, it's not. So we changed plans multiple times, here are my disclosures, in this particular case. And I'll go through that a little bit. So she is certainly not eligible for any of the DISRUPT studies. I think one of the challenges is we're presented with real life. Sometimes they're just garbage coronaries, and we're trying to figure out what we should do at all. So in this woman, she's 85 years old. She presented with dyspnea at rest, ultimately diagnosed with an NSTEMI at a neighboring hospital. Her trope peaked about 23. She was put on a heparin drip and then sent over after this angiogram. So her LAD is effectively missing, but we can still see the roadmap because she has so much calcification there. She probably has disease in the circumflex, but I have a hard time even identifying what's happening in this Medusa thing here, so I kind of ignored that and decided to move on. Her RCA seems to be a little bit more of a target as well, and at this point we have some further information on her. She actually has low flow, low gradient, severe AS. She obviously has the occluded LAD as well, and I'm sorry, go forward again. And ultimately, just to cut to the chase, her LAD territory appeared to be non-viable, and so that was less of a priority for us, even though it's obviously a territory. So she has this, kind of mildly tortuous RCA. It's difficult to lay out for them, but they do a good job in her ARIO view. See if that'll just play. But effectively, there's this area down here that actually looks quite tight on the ARIO view, and she's probably got some moderate disease there more proximally. So in general, my partner Christine Chung has enough guts that she did a TAVR on her because she was quite ill, needing pressors. She's on enough inotropes. We talked about a balloon pump. The patient's kind of refusing that. And in the throes of that, we said, well, we should do something if we're going to be more aggressive with her management. And after a long conversation, they actually did take her to treat the valve first to try to stabilize the situation. Ultimately, she was still struggling. She's in the ICU doing okay, but not well enough. And there's lots of conversations around that. So I think we can go back and forth about a lot of that, but ultimately plan to treat the RCA. And so I think these are cases where looking at it, lots of people have different opinions. You know, she's old, she's really sick, just balloon and stent it and get out of the cath lab as soon as possible. I think that, oh, that's pretty tight, you're going to need rota to get across, so maybe orbital is better because perhaps there's less hemodynamic perturbations. And now that we have IVL, you know, that's just really the way to treat these sicker patients. So I quite frankly actually wasn't too involved at some of the early planning, and this was added on as a DOD case. And then I was supposedly doing my academic time and trying to get smart like all these ladies, but failed at that miserably and got pulled into doing this. So I actually went up to talk to this patient because Dorothy said she refused mechanical support. And we're like, well, we don't really want to do that either, but we don't get to always pick and choose all these things. So we had more of a conversation. She definitely did not like how she was feeling, couldn't go home, couldn't be independent with this lifestyle. She doesn't want to just go on hospice, and sort of ultimately we do decide to bite the bullet. So her creatinine's about 2, which is slightly improved during this from her acute presentation. So we use a wire to get the guide in, make sure we're there, get one setup shot. We figure, well, this would be great if we could deliver IVL, then I think this is a good solution for us to kind of keep things minimally invasive in terms of how much ischemic burden we have and some of the uncertainty there. As it is, the wire goes very easily, but it's actually very challenging to get the microcatheter across. We need to use a 1.5 balloon to even do that. Meanwhile, they came to tell me that our IVUS console that wheels into that room, it's one where we don't have it built in, that's broken. So am I okay with OCT in this case? I'm like, not really. We'll figure that out later. And then she just had this TAVR, and she has some second-degree AV block even before we just put the guide in. So I don't actually usually do a TVP. Aristid's been teaching me how to use aminophylline as a good way to prevent issues with atherectomy. But we actually put a TVP in, and with some of the supply chain issues, even that was a struggle because it was one we'd never used before. That was really flimsy. So we're finally getting started. This old lady's getting a little bit antsy. And we're about 3 runs. My fellow Jasleen is super patient, much more than me. She has no D cells, but the patient anyway goes into VT during rota and has subsequent hypotension. So now things are changing again. Her blood pressure is sort of marginal. We figure she has some no reflow potentially. Actually gave her a whiff of epi down the guide to kind of give us some time to get the rota gear out, take a puff, make sure we don't have a perf. We don't, but I'm not very motivated to keep doing rota. I think without IVL, I probably would have put a pump in just to keep going, or like, are we at a safe place to bail altogether and reevaluate our lives? And I don't know the right answer. But ultimately, with guide extensions, which do cause some ischemia as well, we're able to get serial balloon inflations down. I went through about 10 different balloons, a couple of them rupture, but ultimately we're able to get good enough support and get the guide extension somewhat down, and actually we're able to deliver IVL, which I think was useful in this case. She's still having chest pain. She probably had ST elevations, but she was paced, so who could really tell? But actually she does have some flow here. I wanted to show that case. Anyway, this last angiogram just shows that she does have flow, but there probably was a dissection there in the medial part, and then you'll actually see that at the end where the balloon ruptured too. So I think one of the things we saw this in the live case, it's the time to slow down for a second and do a good prep on the balloon. So we had some back and forth of is the balloon prep good enough, but ultimately we got some results with 80 pulses. We have some ground to cover, but we just focused on the more distal area. And all of our issues, just to show that imaging is really helpful in identifying these things in angiography live, all of our issues were actually up in the more proximal part of the vessel, which I thought was just moderate disease. And that's where we were spending all of our time rotating in the beginning and where we kind of got stuck with all of the balloons. That more distal area I was really worried about actually was much easier to manage and opened up easily. So I think it just goes to show we don't know what we're getting into. Dolores is also not very happy to be on the table with me anymore at this point, which I understand. And so this is one of the rare cases where I actually don't have imaging to show you. Once we got the guide extension down and we had good balloon inflations, we dropped some 3.0 stents and post-dilated them. And elected to leave it at that, in part because I'm worried about contrast and that we had OCT available at that time. So I think that is a highly imperfect case, but sometimes these are the ones that I learn more from, of like, how could my decision making be different? And I certainly welcome input from others on how they might have managed that differently. So I think my takeaways are, try not to get stuck on one plan. You know, if these things change, we can't see everything from our setup shots, and I certainly had some surprises there. And that risk mitigation in these cases really is balancing several factors. So certainly, you know, we love radial, but if I can't deliver anything or I can't manage this without having a guide extension buried the entire case, that's additional ischemic burden as well. And being able to complete this successfully when we get to a safe place to stop ended up being important in her case as well. Thanks.
So our next speaker is Dr. Rasi Moran from the Medical University of South Carolina.
Thank you all. So I'm going to be talking about a case where, honestly, Shockwave saved the day for me. These are my disclosures. So this is a 91-year-old who came in with his 87-year-old wife to discuss PCI options. Patient has been having worsening dyspnea on exertion and lower extremity edema. Past medical history is significant just for AFib, asthma, tobacco abuse. Had an echo and a coronary calcium score in a 91-year-old. Okay, and the calcium score was 1,600, so subsequently had a left heart cath. And these were his meds. And the patient was initially, before doing the workup time, was managing very well, doing very well. The LAT score was 3, but now he's not able to do anything, and the wife who depends on him is not able to, they're just not able to cope. This is his EKG, creatinine is 1.2. He's a very kind of fragile looking person, and this was the baseline EKG, and the heart rate was around 45 to 47 beats per minute in atrial fibrillation. And this is his echo. He has moderate aortic stenosis, also in the same setting. This is his coronary angiogram. You can see a non-dominant right coronary artery, and this is his left system. And for whatever reason, the outside cardiologist took only cranie pictures of this, and all I could make out was, okay, there's possibly a tight left main and there's a LAD lesion. And this is all I had to start with. And by the time this guy came to me in clinic, his heart rate is now, initially was in the 47, now it's in the 44s, and he's more fragile. I'm like, okay, we are not sending you home from clinic. We are going to the hospital to take care of this the next day. And the things factors to consider in this case is very poor visualization of the bifurcation, need for atherectomy in a heavily calcified vessel with a heart rate of 45 beats per minute. And Kate mentioned I don't like to put temporary pacemakers. There's moderate AS, normal EF, but extremely frail person with very little reserve to lean back on. So I decided, even though EF was normal, I decided to go with a single impeller support because, as I said, there's no reserve. If something dissects, I'm going to be in trouble. So 6N French Teramo sheath is what I use when I use single axis impeller, and a 7 French EBU. This femoral angiogram doesn't do justice to what I had to suffer because the aorta was going from right to left to right to left. Had to use Amplat super stiff wire to get the JR4 up to cross the LV, and by which time it took us about 25 minutes just to get the impeller up. And this is a Friday afternoon case. And then I tried to get my EBU 375 through the single axis. It's just not reaching because it's just too much tortuosity and it's just not reaching. There are too many kink points, and my angiogram is no better than the outside hospital angiogram. I'm not able to get good pictures. And as I said, very tight knuckles. And then somehow we try to get the guide in, and I'm like, okay, this is going to be easy. This is going to move on very quickly from now onwards. And I wire the circumflex, and I am not able to wire the LAD. And it's another 20 minutes into the case. I'm not able to wire the LAD. I've taken a dual lumen catheter. I've tried to put an IVUS in place. And by which time I realized this guide is not working. I have zero guide support, and my equipment was getting kinked outside because of the dual So in a fully heparinized patient, we decided we are going to get a separate second femoral axis, and the single axis plan was not working. So we got 7 French axis, got a 7 French EBU from the left femoral artery, and now we have some support. But even then, I am not getting into the LAD. We put an IVUS in place, trying to visualize maybe I can, get something in, and I will do IVUS guided wiring of the LAD, but not working. Then at this time, no, I can't go back. So at this time, I decided I'm going to IVUS the circumflex, okay, and this is the IVUS of the circumflex right here. Trying to see, to understand the ostium, where is the left main ostium, where is the LAD, and again, it just blurts out and comes off into the aorta per se, and I'm not able to have a good visualization of the left main ostium itself. So I see the calcium in the circumflex, so I decided I'm just going to shockwave the circumflex right now, and we did extra pulses, more pulses focusing on the ostium of the circumflex, and then I still can't get a wire, that's still a problem, so I decided to put an occlusion balloon in the circumflex and took my Xion wire and decided to hopefully knuckle into the LAD, and that's me floundering around there trying to eventually enter the LAD, and the wire goes into the LAD. And this is where honestly I was so happy the impella was in place, because if you remember, this is a left dominant system, and I just occluded it with a balloon to do this. But this was the crucial point of this. And Xion wire is the wire I like to do when I'm doing this knuckle technique with the occlusion balloon. And now, after that, I'm finally trying to get pictures of the LAD, and the LAD has a big tortuosity here, and I'm not able to deliver anything over this little bend here. And I IVUS the LAD also, and I'm still not able to understand the ostium. It appears to me that this is a dual ostium situation. And this is the IVUS of the LAD again, and you can see the calcium there, and the tortuosity, and the IVUS would go only proximal to that little bend. And we tried it 3 times and with a guide extension, but just could not do it. So again, there you go. That's your ostium, and then you see the second wire, but it's in space. It's not truly in the left vein, and you get into the aorta. So I'm still trying to figure out what strategy I should use here to treat this left main ostium. And now we use the guide extension catheter, dealt with the guide extension catheter, stent that LAD, and I decided to do simultaneous kissing stents with 1 wire, because I thought if I have to do any sort of DK crush or cool out, I will have to swap wires, and there is no way I can lose wire access in any of the vessel, given the amount of time it took me to wire the LAD initially. So we decided to do simultaneous kissing stents and balloon them again without losing wire access. I tried to IVUS after that, and my IVUS catheter actually broke, and my team was like, no, you're not getting a new IVUS now. You're done. And therefore, and this is my final angiographic result. So take-home points. Iliac tortuosity can be a big issue with single-axis impella. Intravascular imaging, again and again, I think this is the recurrent theme. And shockwave lithotripsy can be used to modify the plaque at a bifurcation. And that was the true key to success in this case, because there was some sort of a calcium nodule right at the LAD ostium, and I was able to use the circumflex ostium to modify that plaque, and then I was able to wire into it. And sometimes you truly have to walk away with the simplest strategy. With that, thank you very much for giving me this opportunity.
All right, so thank you, everyone. This is a calcium modification in a left main trifurcation where I up front was planning to use MCS. Here are my disclosures. 63-year-old female, history of NASH. She was complicated by esophageal varices and cirrhosis. She's currently undergoing weekly paracenteses. She noted to her daughter that she was having progressive shortness of breath, and to the point that she was pretty limited in what she could do around the house even. Her daughter instinctually and good took her to the emergency room, and she was found to have an elevated troponin. And an echo was done while she was in the emergency room showing an EF of about 25-30%, so a diagnostic cath was ordered at that hospital. And you can kind of see already that there's some disease. So the outside shots are kind of limited, but you can see there's some haziness towards like the distal aspect of what the left main is, some mild disease then beyond in the circ, but really not seeing what's hiding behind here where the LAD is literally holding on by a thread. And then she has this lovely RCA CTO to kind of just combine everything for her. With that being said, she was sent to our hospital for a surgical evaluation, but quickly declined from surgery as a result of the NASH and her overall long-term outcomes not being maybe so great at this point. Her medications were optimized, and then she was brought to our hospital for PCI. She did undergo MRI, which confirmed that actually all territories were viable. So with that being said, we brought her in, and I was fortunate she had good iliacs that were not tortuous, so I did the single technique Impella with a 7 French EBU 3.5, and it fit well. And this time I actually took a real caudal projection, which wasn't provided prior to the procedure. So a lot of my strategy I wasn't necessarily prepared for up front. I didn't realize that there was going to be this high OM branch that was there, or ramus, however you want to call it. But her prox LAD was certainly an issue, and then the circumflex had some haziness there too. So I opted to start with wiring both the LAD and the circumflex. And my kind of algorithm when it comes to calcium, if I can deliver a microcatheter or my imaging catheter, I'll probably be able to get IVL in there. If I can't, then I'll consider rotational atherectomy up front. After I had wired these two, I thought in my mind that maybe I should just protect that OM too, because it's still a decent amount of territory, and I don't want to lose anything for her knowing that she has that RCA CTO. So I did IVUS both of these. In the interest of time, you can believe me, and she had pretty good circumferential calcium as we get up to the more proximal vessel. So I decided to pre-dilate both vessels with 2.5 balloon, and I had limited expansion, but by IVUS distally, I was able to do a 3.0 millimeter shockwave into both the LAD and the circumflex, and got good expansion after that. With that being said, knowing that I had some disease in that high OM, but I wanted to avoid sort of trifurcation stenting, I decided just to do a cutting balloon for modification there, and then ultimately moved on to a 2-stent strategy for the left main into LAD and circumflex with DK crush. And I put a 3 by 38 in the left main and LAD, post-dilate that with a 3.0, and did a 3.0 24 in the circumflex system, and did proximal optimization with a 4.5 in the left main. And this is my final cranie and my final caudal, and before and after. So I think she got a decent result. With that being said, we were able to wean the Impella post-procedure. She actually did remarkably well hemodynamically throughout the duration of the procedure. She was discharged 2 days later. She was seen in clinic roughly 3 months after this with an EF improvement to 45, and symptomatically, she was back to kind of her normal routine. Her RCA CTO is still there. With that being said, certainly we all deal with calcium. Calcium is everybody's worst nightmare, but knowing to modify that ahead of time and using imaging up front is the key. The last thing you want to do is have stent regret and put in underexpanded stents, and I think all the information that we've kind of obtained from today is important that we think about what strategy we're using for patients, particularly females that have a lot of disease. With that being said, thank you.